Welcome to our webinar, Movement is Medicine, 5 Ways Movement Reduces Pain. At Pain Care Labs, we've been very interested in vibration for pain management for a long time, but I think that the consensus is understanding in the pain community that pharmacology is not going to be the direction that pain management goes, and instead, the biggest advances that are being made in research are in movement. So today we're going to talk about pain itself, new neuroscience, and starting there, I want you guys to be the ones who can correct or explain this to anybody. So actually the real reason that movement works, we'll talk in the context of stiffness and fascial pain. We'll talk about chronic pain and this cool understanding of brain-derived neurotrophic factor, which is like brain fertilizer. We'll talk about how movement interacts with regeneration. And then we're going to talk about the new understanding of how pain pathways and connectomes influence what we feel. So now a word from our sponsors. Vibracool is available at paincarelabs.com. And it is a combination of 2 different physiologic interventions, vibration and cold, with compression to hold it where you hurt. So biggest comparison we often get is, how does this relate to E-stim? E-stim is electricity that's triggering light touch nerves. M-stim is vibration in the right frequency to trigger the motion nerves. So you can use it with a pacemaker. All right, so the cases we're going to talk about today are somebody with chronic pain whose name is Amy Baxter, and this is my MRI of my rotator cuff and biceps tendon injury. We'll talk about sharp pain and how sharp pain is interpreted and can be overcome with motion. And we'll talk about stiffness and fascial pain with a little foreshadowing of some early data from our low back pain studies and device Duotherm. So talking about pain itself, when I was in medical school, we got 2 days of lecture over the whole course of 4 years on pain. Kind of vaguely knew that pain happened in the brain, but didn't know where. And we learned that this is the sensation cortex. It turns out that now that we have the ability to see where the activity is in the brain with pain, we know that pain lights up sensation and the thalamus and the anterior cingulate cortex, which is the decision switchboard. And once it decides you need to worry about pain, then it sends the information over to fear and memory and options and meaning. So pain is happening all over your brain. What this means is that a lot of what you experience as pain is actually memory or context from previous experiences. So when you initially move, you may feel pain, but then if you move a little bit more, your brain's like, oh, okay, I remember that that used to be really painful, but now it's not, so I can stand down. So what this means is that even little micro movements can be necessary to tell your brain memory, oh wait, that doesn't actually hurt anymore, or that's tolerable pain. So the more post-traumatic stress associated with untreated pain, the worse the pain's going to be. The brain's size reflects these memories that are being laid down. So the thalamus, which is kind of the brain's CPU, will change shape over time with pain. It can be reversed though, like after a total knee replacement, 6 months later, it's back to a normal size. And we know from every procedure, from IV access to giving blood to making your arm, broken arm fixed, we know that anxiety correlates with pain. So that's because the amygdala, the fear area, is connected with this pain matrix. Consequently, this new understanding of pain itself means that there's not one drug that's going to fix the problem. So with this understanding, let's talk about movement and gait control. So this young woman has a knee arthritis at an early age. She needs a replacement, but there's so much pain being transmitted from this arthritis that she doesn't want to move or walk, and thus she can't get stronger. So how does movement decrease pain for her? So gait control is this concept that you've got light touch, pressure, stretching, and motion nerves that are all going to the spine. Now, the A delta fiber is sharp pain. So that is going to the spine on very thin, fast, myelinated fibers, which means that they're insulated, so they go quick. These are the fibers that you can stop with something that will gum up those little connections in between, like the little ends of the hot dogs where they connect. So in between each of those buns, that's where sodium is released, and that triggers the next one. So consequently, you can use sodium channel blocking drugs. This is like lidocaine, or we use creams, lidocaine plus prilocaine. All of the canes are sodium blocking drugs. Now, movement is done on a beta fibers, and those are the big purple ones. And so these are those touch nerves that are transmitting. And when they get to the spine, they actually block out the pain transmission. And so you don't get that sharp A delta pain. Instead, you get the much bigger sensation of motion. It turns out that there is a specific frequency of motion that is optimal, and that is high frequency, about 180 to 250 hertz. So the way that for this woman, motion is going to decrease her pain, she can even have passive motion. So putting vibration on can numb up these nerves and override the pain signal actually reaching the spine and the brain. There's multiple studies looking at this high frequency mechanical energy, like vibration. This one is particularly comparing it to tens. So what you're seeing here is that the solid lines are tens and the dotted lines are vibration. And so the same people coming in on different days and getting either tens or vibration, the vibration was more effective after a 20-minute session. And this is because the micro motion on the tissues is decreasing the pain signal. Now, E-stim is used for pain sometimes, but it's not actually causing motion, so you're not getting that movement effect. What E-stim is really good for is anything that the light touch nerves help. So if capsaicin is helping, if the hot creams that actually destroy the little bitty A delta nerve endings, if that's working, then E-stim would work. If you've got neuropathies, then sometimes E-stim will work for that. But for motion, you need to have mechanical stimulation. What we're finding is that there are a whole bunch of different frequencies of motion and different amplitudes that work for different things. So the next thing we're going to talk about is stiffness. 30 to 50 hertz, but with a pretty big amplitude, like standing on a vibrating plate, both improves balance, but it also decreases pain. For delayed onset muscle soreness, using lower frequency vibration stops the creation of lactate and a bunch of other catecholamines that are pain related. And so it decreases the pain a couple days later. The other thing that you get from vibration is increased blood flow. So that motion is going to decrease, that motion is going to take the blood flow that's got these catecholamines and move it away. And also increased blood flow helps healing. And so by repairing the tissues, it decreases pain. Any kind of motion that's applied is going to help pain. So really, so things like yoga or stretching, those slow movements, those are operating the Ruffini corpuscles, and those are going to help with pain also. Because not only are you getting the direct pain effect, but you're also having the micro movement that reassures your brain that if I do this slowly enough and it doesn't hurt, then this movement is not something that I need to get alarmed about next time. So your brain adapts to know that those slow movements and those stretching movements mean you don't need to hurt from that area. It doesn't need to overreact. Other things that can help pain with movement are very intense, small movements like acupressure or pushing on myofascial trigger points. This is moving, physically moving those small little places where the nerve and muscle bundles are tight together, and those cause pain. Now, microneedling can help those, and we don't really understand why, but I think we're going to soon, because let's talk about fascial movement. This is super exciting. I was lucky enough to be at the American Academy of Pain Medicine and hear the director of the National Institute of Complementary Medicine. Her expertise is in fascia. And one of the cool things that she said was, you know, we know all about, not all, but we know a lot about the pain that happens on the surface, but we know almost nothing about the pain that happens in the areas that connect muscles to other parts of the body, ligaments and tendons, and to know about the stuff in between the muscle tissue and the fascia that covers up the muscle. So all of these different things connecting it are really a completely unexplored area. I want you to see these ultrasound videos that she showed that were from a 2011 paper that she did. So first of all, watch how this area just below the muscles that are just below the skin surface in the back, look at how smoothly they move in somebody with no low back pain. So what you see is that each layer is kind of moving independently, and it doesn't look like it's caught up on anything. They're just, as somebody is moving, all the different muscle areas move at their own speed independently. Now look at the fascia of somebody who's got back pain. They're doing the same movements, but first of all, you see there's very little stretch. Second of all, you see that it's all kind of moving as one chunk. It's not sliding over itself and moving smoothly. So we don't know what the pain nerves are that are taking signals from all of these different parts of muscles. But what we do know is that by being stretched and loose and being able to move, pain is reduced. So movement that's able to increase mobility and range of motion is going to decrease pain. Now, we've been working on a low back pain device that combines different frequencies of vibration and hot and cold. But I want you, and so this is our cool promotional trailer. What I really want you to do is listen to this video for how people are talking about their pain and motion and looseness. Here we go.
I hurt my back when I was a freshman at West Point.
I was chronic back pain for years. I had a discectomy a year ago.
I'm Dr. Alan Hoffman, and in 1983, I injured my back while on active duty as a combat medic in the United States Air Force.
All right, so you've got three different kinds. You've got an injury, you've got nerve pain, and you've got somebody who had a twisting injury.
Vibration, massage, yoga, exercise, those aren't things that most physicians think about recommending.
Making things look simple is always our goal, but this is a very complex device. So this is a FDA cleared device.
I'm gonna scoot ahead a little bit. Yeah, it's true. That's all good. Okay, so now let's listen to them.
I've never found anything that combines vibration and heat or cold.
After using the duotherm for a while, I think there are a significant number of advantages over 10.
My back feels so loose. I'm like really impressed.
When I wore the duotherm into work for the first time, the most interesting comment I got is that, Dad, you look better. You're walking a lot better than last time I saw you.
So he's more mobile.
For the nerve pain. What the problem with my back is. Nothing has worked as well for me as the duotherm.
When I got duotherm, I thought it would be like everything else that I had tried. I was just dumbfounded that my back released and it was relaxed and I didn't have any pain.
And I was
So I think that both of those are really interesting. So you've got somebody with nerve pain, somebody who had a discectomy, which also one would assume is that there's a nerve-related issue with the vertebrae in the spine. And then you have somebody who had a mechanical issue from an injury in West Point. And all those three different mechanisms, people talk about how the looseness was what helped. The other guy, the Ed who said, oh, you're moving better. Again, it kind of implies that it was the stiffness trying to protect the back itself that was causing pain. Okay, we'll keep going a little bit.
Worried about some of the long walks in the airport with this back pain. So I was able to use my duotherm and just like this under my clothes on the plane. And it worked fantastically.
I've got greater endurance, more flexibility, and I highly recommend this device for anyone who has acute or chronic low back pain.
I've tried many different things. Neurotherm is really good value.
I have been on my feet all day long. Put this on and my back feels amazing. I love it. I want one forever.
We need this now. We need something that can address pain.
All right, I'm gonna make you watch the rest of this because it'll be relevant.
By giving people options. We're on a mission to change how people treat and even think about pain.
We'll come back to this options thing at the end of this, talking about movement. So the thing to me that's really telling about this, and the reason that motion is medicine, is all of those people have a different etiology of their back pain. You've got somebody who's got nerve pain, injury, disc problems, and you know, an acute spasm that was pulled while the guy was working out, even though he doesn't tell you that's why he got pain. But with all of them, motion and stiffness were the equivalent to no pain and pain. Stiffness caused pain, and it didn't matter what that mechanism was. So I think that is really indicative of where the field will go, because we don't know why all of those people have pain and we can't see it. Now, there is a really cool thing that is available now in PET scans, and it's called the SR protein. And so the SR2 protein, it's a pain chaperone. And so you can actually radio label this little guy and then send it out and look at a PET scan and see where pain is happening. So we might see that it's in the nerves or in the muscle or in the bone, but I wouldn't be at all surprised if what we see is the supporting muscles in the back is really where pain is happening. And that's because of a fascial mechanism that we don't know yet. All right, so how does motion overcome pain? It's decreasing stiffness. So stretching is going to be making that fascial component more able to slide smoothly, as well as decreasing the fear of movement that increases the pain's perception. And by using microvibration, and by using vibration, we're stimulating microhealing, reducing the inhibition of movement, because if it's already been moving, it's not going to trigger that immediate pain response. And as we've discussed, it increases blood flow. Now, one thing that's interesting is there are some studies that show that both whole body vibration, which is at about a 20 hertz and it's standing on a plate, that you can get some of the same release of pain inhibition as you do with putting the vibration on directly. So for some kinds of pain, it doesn't matter where you're getting your external motion from, they're both effective. And that again points to an inhibition or a fascial movement cause of having the pain. All right, so here we go. Oh, by the way, all of those people are real. There's no actors. We wouldn't do that. Okay, now let's talk about chronic pain and how movement decreases pain and also increases regeneration. So this lady is not having the same pain I did, but it is still relevant to anybody with chronic pain. All right, my chronic pain came because I fell in November and ripped 3 muscles in my rotator cuff and didn't do anything about it because I thought it'd be fine. It was Christmas. I'm busy. Then I started having more and more pain, and finally in March got an MRI, and there's that the whiter stuff here is what should not be there. This light, bright stuff, that's inflammation. So oops. And I started looking into how much just any little movement hurt, and it was because my body wasn't sure if it was dangerous for me to move or not. So it said, let's just have pain and not move. Turns out that the micro movements actually reduce pain. So having just really like physical therapy, tiny little movements, what they're doing is in part, they're regenerating those areas. There's something called Wolff's Law, which is that oscillatory mechanical strain or any mechanical strain causes growth. So this is how you can have tiny little movements that start reversing chronic pain. In the body, the tissues are stretched to a certain tension. And when you're not using one set of muscles, other muscles that are adjacent start taking over. And they're not used to that much pressure and motion. So they get more tense because they have to carry the burden. That decreases the blood flow to them, that increases pain. So by doing very small movements to get your main muscle back, taking the load it's supposed to, you can reduce pain. Now, another way that the small movements can help with chronic pain, particularly after an injury, is that all of the receptors on both muscles and at the cellular level have a little shock absorber. So by having any kind of movement, you're starting to repair and reduce pain. Now, one of the reasons that this is relevant to general chronic pain and not just a very specific one is because of how the brain is processing pain. There are a lot of chronic pain conditions now, like fibromyalgia and pain after COVID, that we believe are likely ongoing inflammatory damage that can be throughout the body or that can be in the fascia or the muscles. So this ongoing damage is constantly elevating your brain to be concerned about pain. One thing that high intensity exercise does is it increases something called BDNF. So BDNF is the fertilizer for the brain. It's called brain-derived neurotrophic factor. And as you experience chronic pain, you're laying down tracks between those connections from the anterior cingulate cortex to fear, anterior cingulate cortex to the hippocampus where there's memory. And those connections get stronger and stronger. And BDNF is what is doing that remodeling. But you can remodel it the other way with exercise. So studies have found that the most effective way to reduce the effects of chronic pain is high intensity exercise. And it doesn't have to be where you got hurt. Turns out it does need to be about 10% over your resting capacity. So walking mild stuff doesn't work. It actually needs to be a little bit elevated. I mean, intense works better. 10 minutes is enough, but it doesn't have to happen where your pain is. So I can't tell you when I learned this how motivating it was to go and do an elliptical, which didn't impact my shoulder at all. But the next day, my shoulder felt better because of this BDNF and the intense exercise. It does not work. Weight resistance, weight training, those things help in other ways, but they're not working via this brain-derived neurotrophic factor mechanism. But this is pretty cool, in my opinion. All right. Now, I've said thanks and questions, but I am going to go back a little bit and talk, before I get the questions, about this brain part. So, where are we? There we go. I'm going to talk a little bit about this. So what we know is that the context of what you're feeling influences your pain enormously. So by doing gentle movement, you decrease the memory association with moving that part of your body and pain. By doing standing vibration or stretching, you also make the fascia tissues move more smoothly, so you're not triggering nerve pain. By feeling comfortable and moving, you're also increasing endorphins. So we didn't even talk about the fact that it turns out, this is awesome too, turns out that the runner's high is actually not activating the same endorphin area that opioids use. Runner's high is actually activating cannabinoids, like the same receptors that feel that THC activates motion, running, activity, intensity. that's acting on the cannabinoid receptors. I don't know. I just thought that was cool. So, so now there you go. So we know that gait control and vibration reduce pain with motion directly. Stiffness and fascial pain contribute heavily to pain. And so by increasing flexibility and decreasing stiffness, you're decreasing the pain that comes from the interstitial fascial area. With chronic pain, having high intensity exercise is going to trigger BDNF to help reverse the effects of this chronic pain. We know that blood flow from motion and vibration or any kind of weight-bearing activity, that's stimulating those integrins, which are going to help with regeneration. And we definitely now know that the motor pathways in the brain connect to emotion and connect to memory and connect to context and connect to what you perceive as pain. So the more you can be comfortable moving, the more it helps you ignore pain and feel less of it. All right, I am delighted that you all joined in. If anybody has any questions about how movement is medicine, please write them in the chat. One question that I have had myself and have answered is, what if you don't know if something is damaged? So obviously, before you start doing movement, one of the things that your brain is telling you is to be safe. I mean, pain's kind of nagging you about, maybe wrong, but it's pain exists for your safety. So if you think about whether you're safe or not, if you feel a twinge and you're worried that it's cancer, you're going to keep feeling that twinge until you know that it's not. So as soon as you know that something isn't dangerous, then it'll reduce your pain. So if you don't know yet, go ahead and get that MRI or get that test or have somebody evaluate it to make sure that there isn't something there that's dangerous. That said, if you know that there's not something, do actually practice thinking about pain and saying, you know what, I know that it's okay for me to make this motion, even though it hurts. I'm just going to tell the pain to stand down or try to ignore it because I have to do this to get back my range of motion so I can not have the pain. So yes, make sure that you don't push through things that are damaged. So all of these motion things are really about in the context where you've been diagnosed and you know you're okay. Any other questions besides our personally generated ones? Oh, all right, so I've gotten the question of when is the Duotherm available? We are currently in our phase 2 NIH trial. There are some available because the people who did an Indiegogo campaign got the first ones off the line. But in terms of widespread availability, those are actually going to be typically, I think the first round is going to be prescribed from surgeons and from other doctors or in the context if an epidural fails. So 2024 is the best guess, but it won't be too long now. Any other questions? Yeah, so BDNF, does it help with overuse injuries as well as acute injuries? So BDNF is more of a chronic pain factor. And what it's really doing is it's just assessing where things are in the brain and making it more efficient. So if you are used to if you're feeling chronic pain and you need to remodel the brain so that you can feel more pain more efficiently, it does that. However, when you do exercise, it realizes you don't need all of that. And so then it kind of tidies up and clears away those connections. So overuse is going to be more of a situation where your BDNF comes into play. And it's, there are a lot of different hormones in the body that both, go up or down depending on the context. So it kind of behaves as a hormone in that kind of a way. But it's really, BDNF is not something. Now, this is interesting. I don't know if BDNF starts working immediately. There is some new research from the NIH that shows that there is a receptor that can be blocked to prevent chronic pain. So it is possible that that receptor, and it's time sensitive. So like you have to block it in the first day or two after pain starts. Or of course, in this situation, they're actually slicing rats and hurting them. And then chronic pain starts unless the rats exercise, in which case it doesn't. So, but it's a very sensitive, time sensitive thing. Scratch that. The pain starts unless they block the receptor. However, with these other rats who are injured, if they start exercising, they don't develop chronic pain either. So is it using that receptor? Is it not? Don't know. But definitely there is a mechanism where exercise reverses or prevents chronic pain. How does genetics influence pain? So that's a really great question. And the primary answer is we don't know. But I'm sure that it does. And what's interesting is that there are certain people that are prone to one kind of a personality type that probably is a brain chemistry response. Like there's 4 different dopamine receptors. And so people that respond highly to dopamine 2, which is also where cannabinoids hit, may experience less pain than people that are not strongly motivated by that dopamine 2. Those people also tend to be more prone to having depression. So there's a lot of genetics that are at play with the neurochemistry that are going to impact pain. Now, there certainly are genetics like melanocortin 3 receptors, and those are the ones that redheads feel sharp pain more intensely. So there are definitely genetics that come into play with that. But I think that I mean, my back of the envelope estimation is that the pain you feel is about 1/3 from the nerve input and 2/3 from your brain response. So clearly the neurochemical and neurobiology and the genetics that impact the way that medications fit, the pharmacogenetics, all of that stuff comes together. And I imagine that has more to do with pain response than just the physical input that's coming from the nerves. The pain chaperone. Okay, yeah. So can I explain the pain chaperone I mentioned? So it's not, so a pain chaperone is just a protein that has been discovered that goes to areas of pain. And so you can radio label it, you can put a ligand on it. So you can do something that will attach to this SR2 molecule, and then you can put people in a positron emission testing, so a PET scan, not an MRI, and then these little molecules would go all over and find pain and stick there. And so then you can see where the pain's happening. The coolest application of this was an article in 2017 where a woman who had phantom pain from an amputation, nothing was reversing it. And so they did this and they found that there were a whole bunch of these little chaperone proteins that glommed around the end of a nerve that had grown in on itself. And so it was like she had an ingrown toenail, but it was ingrown nerve ending. And so when they zapped it and got rid of it, the pain went away. So I think that there are both diagnostic and therapeutic applications of this, but it's being done out in Stanford right now. I don't know how readily available it is, but it's kind of a forefront opportunity to understand pain. All right, well, as always, I very much appreciate you coming. Please look at our other videos and webinars if you have any questions. We do have an opening in May for a subject that people want to know more about. So whether it's about decreasing needle pain, whether it's about physiologic pain, whether it's about vibration and pain, I don't know, that's probably all the stuff I know about. But let me know if you've got a question, nasal irrigation, and we'll do that for the webinar in May. Thank you so much, and it's going to be fine.